Hi, we're representing Carroll University's Master of Science in Clinical Exercise Physiology program. We've been collecting data for this research throughout the past academic year and appreciate you taking the time to listen to what we've found. We investigated whether ventilation rate could be used as additional VO2max criterion in graded exercise tests.
As clinical exercise physiologists, it is our duty to fully understand a population's disease, limitations, toxicities, and outlook. With the diagnosis of cancer being the second leading cause of death in the United States, there is a call to action to those within our field to aid this population. Though diagnoses vary, treatment options often include surgery, radiation, chemotherapy, and immune therapy. It should be noted survival rates have risen due to the available treatments, yet at the cost of negative side effects. As supported by the 2022 ACS Medical Content and News, the risk of death from cancer dropped by about 2% a year from 2015 through 2019, compared to 1% a year during the 1990s. Chemotherapy and radiation treatments have been shown to cause physiological strain on multiple systems, of which the cardiovascular system experiences significant damage, which in turn patients are often seen to present with diminished left ventricular ejection fraction, hypertension, QTc interval prolongation, arrhythmias, and vascular diseases. Within our field of clinical exercise physiology, we use our knowledge of physiology and specified exercise intervention for rehabilitation. A clinical exercise physiologist within the cancer setting provides cancer-specified protocols, individualized exercise intensity, decreased risk of mortality by meeting ACSM exercise standards, focusing on activities of daily living, and support throughout treatment and remission. The ultimate goal for our patients are to increase success and outlook, increase treatment tolerance, and decrease the effects of cardiovascular toxicities. However, with each clinical population, relevant and accurate criteria must be incorporated. From specified functional and exercise testing, termination criteria, classifications, and rehabilitative protocols, all must be precise to the specific clinical population. Physiological benefits of exercise for those diagnosed with cancer include reduction in depression and anxiety, fatigue, bone and muscle loss, and fall risk, while improvements include increased quality of life, sleep, effectiveness of treatment, and prevention of diseases like heart disease and control of other chronic diseases. Respiratory frequency refers to the rate of breaths one takes per minute. This value is equally essential to other vital signs such as heart rate, blood pressure, and oxygen saturation. As there are classifications of an ideal respiratory frequency of 12 to 16 breaths per minute, an RF that is abnormal may give clinical indication. A varying RF can provide further insight into a subject's health status. For example, an elevated RF can reveal emotional state representing anxiousness, level of physical fitness, internal temperature, as a higher RF may be correlated to fever, and possible heart disease or respiratory health concerns. Our focus is related to the current cardiovascular capacity and the termination criteria of maximal testing relative to the cancer population and the cardiovascular strain. As those diagnosed with cancer are already experiencing negative effects on the cardiovascular system, current termination criteria, such as 85% heart rate max and RPE, are reached at a faster rate at a lower workload. With the cardiovascular strain in mind, our cohort analyzed the use of peak breathing frequency, or RF, to be used concurrently with established termination criteria of maximal testing. As RF increases linearly with intensity, the subject would be required to meet greater than 40 breaths per minute, along with an RPE greater than 7, greater than 85% heart rate max, and RER greater than 1.1 to be considered at maximal exercise. Our study followed if RF is significantly differed between each maximal termination criteria. Additionally, we further investigated if RF is significantly different between each of the treadmill protocols conducted. We would like to contribute to the field of clinical exercise physiology and those diagnosed with cancer, a possible secondary termination criterion. The secondary use of a ventilation rate of greater than 40 breaths per minute is valid when compared alongside primary termination criteria.
This experiment used a repeated measures design analyzing cardiorespiratory fitness using a multitude of variables such as VO2, RF, rate of perceived exertion, heart rate, and RER. 40 cancer survivors participated in the research study, all of which completed the cancer, modified Bruce, and bulky wear treadmill protocols 1 week apart in a randomized order. The absolute gold standard in measuring and recording VO2 during exercise tests is with a metabolic cart using gas analysis. VO2max values were obtained via a Cosmed brand metabolic cart utilizing direct gas analysis. Direct measurements in real time as a subject is breathing is a valid and reliable way of obtaining an accurate VO2 value. All on the same line, by utilizing direct spirometry, respiration frequency is recorded in real time. RER, heart rate, RF, and VO2 were continuously monitored and recorded throughout the test via Cosmed and placed into a datasheet where records could be kept and reviewed post-test. Other vitals, including blood pressure, RPE, SpO2, were also documented through the test per each protocol and again at completion while monitoring subjects' recovery. RF and RER were collected by recording the highest values within the final 30 seconds before maximal VO2 was achieved. Up on the screen now is the cancer protocol. We see that this is a multi-stage ramping protocol that increases by speed, incline, or both with every minute. With a low initial starting intensity, the protocol is perfectly suited for cancer survivors who in most cases have low functional capacity. Having stages that last 1 minute each allows for pinpoint accuracy in estimating VO2 when necessary. The other two protocols were the bulky wear and a modified Bruce. The bulky wear is a multi-stage protocol with fixed speed and ever-increasing incline. Originally designed for use in cardiac setting, the gradual incline with fixed speed allows for a smoother adjustment for a participant from stage to stage. As the test progresses, only incline increases. With each stage lasting 1 minute, it allows for an accurate VO2 estimation when needed. The modified Bruce is a multi-stage ramping protocol with stages lasting 3 minutes each. Intensity increases by speed, incline, or both depending on the time in the protocol. Compared to the Bruce, the modified Bruce has a less intense incline to start the test. Compared to other protocols in this research, intensity increases at a much higher rate and fatigue can set in quickly. Due to the aggressive increase in intensity, it can be difficult for some chronic condition patients to perform, especially those with reduced functional capacity, such as cancer survivors. Before each test, a thorough explanation of how the test would progress, when vitals would be taken, a goal of 10 on the modified Borg scale, and handrail usage would be given. Participants would complete the protocol to perceive maximal exertion. After termination occurred, participants would be placed in a cool-down phase to monitor vitals and ensure safety. Analysis of the data collected from each protocol conducted, including subjects' vitals, RER, heart rate, RPE, VO2, and RF. A Cochrane's Q statistical test was performed in order to find significance between established VO2max criteria across the 3 treadmill protocols selected. A done post hoc test was performed to further explore significance between single variables. By running the done, we were able to compare each variable to each other, further increasing our understanding of how the body handles stress of a VO2max test. A significance level of P less than 0.05 was used to determine statistical significance.
The subject demographics that were represented in our research included 40 total participants, 11 of those being males and 29 females. Those 40 subjects presented with various cancer diagnoses. Some of these included breast cancer, prostate, ovarian, and brain cancer, as well as Hodgkin's lymphoma, leukemia, and multiple myeloma. In total, there were 17 cancer types that were included in our data, each with separate courses of treatment. 107 or 89.2% of all treadmill tests achieved greater than or equal to one previously established primary VO2max criteria. Of those, 43% achieved an RF value of greater than 40 breaths per minute. After running the aforementioned statistical tests, RF was shown to be statistically different from the primary VO2max criteria, presenting with a p-value less than 0.05. When looking at the percent of total treadmill tests that met each of the VO2max criteria, 80% met a heart rate of greater than or equal to 85% of their age estimated heart rate max when using the Tanaka equation, 84% met a respiratory exchange ratio of 1.1 or greater, and 89% reported reaching a rate of perceived exertion of greater than 7 on the modified Borg scale. Another key finding from our study was that RF was significantly different from all other established VO2max criteria achieved within each protocol. Within the modified Bruce protocol, heart rate max, RPE, and RER criteria were met 79%, 90%, and 84% of the time, respectively. Only 27% of subjects achieved a respiratory frequency of greater than 40 breaths per minute. Similarly, when looking at the outcome of achieved criteria in the cancer protocol, heart rate max, RPE, and RER criteria were met 85%, 92%, and 89% of the time, respectively, while only 62% of subjects achieved a respiratory frequency of greater than 40 breaths per minute. Within the bulky wear protocol, heart rate max, RPE, and RER criteria were met 85%, 84%, and 78% of the time, respectively, while only 41% of subjects achieved a respiratory frequency of greater than 40 breaths per minute. Our data showcases that RF is an invalid measure of VO2max, even when looking at each variable independently within 3 different treadmill protocols.
The cardiovascular system may be impacted by chemotherapy and other cancer-related treatments that may lead to ventricular dysfunction, resulting in heart failure. Lack of cardiac output from a weak or thickened heart can result in blood pooling in the pulmonary veins. This may lead to low levels of oxygen saturation and a decreased ventilatory response. Another system that may be impacted by breathing rates is the pulmonary system. Impaired alveolar diffusion from cancer-related treatments leads to insufficient ventilation. This results in decreased oxygen consumption and carbon dioxide production. Hypoxia results and decreased breathing rates follow. Also, weakened internal and external intercostal muscles that play a role in inhalation and exhalation may decrease breathing rates. Cancer-related toxicities decrease muscle integrity, force, and muscular contraction. This may result in shallow breathing and a reduced inhalation and exhalation rate. Lastly, liver dysfunction may result in a poor ventilatory response. Reduced breathing rates are correlated with a history of liver dysfunction. Cancer-related toxicities lead to liver problems such as cirrhosis. This condition may result in the inability of the liver to remove damaging substances in the digestive tract before being sent to the rest of the body, most importantly being the lungs, ultimately resulting in constricted blood vessels, which may slow down the rate of air being inhaled and exhaled out of the lungs. The research behind decreased breathing rates is limited, and further research is needed to expand on these mechanisms.
While conducting our research, we were limited by the following factors. Due to the ongoing changes of schedules between both subjects and researchers, tests were not always able to be completed exactly 1 week apart, resulting in variable testing dates. Some situations we faced included a need for childcare, changing work schedules, sickness, and inaccessibility to testing facilities. To make up for these barriers, some tests were administered less than a week apart, while others were run with a larger gap between the tests. This can be seen as a limitation because if tests were run with inadequate recovery time between them, it can result in the subsequent tests providing inaccurate results and data not reflecting the true maximal values. Furthermore, the subjects were not screened regarding any food or beverage intake on the day of testing. Some factors that have the potential to change exercise variables include caffeine intake, hydration status, and recent dietary habits. If the subject arrived having had caffeine within the past 4 to 6 hours, this could result in an increase in resting heart rate, increase in resting blood pressure, as well as an exaggerated vital responses during exercise testing. In addition to factors such as caffeine intake and hydration status, there are many environmental factors that could have negatively affect pre-exercise vitals as well as performance status when testing. The most commonly seen of these include lack of sleep the night before and increased stress levels. With a heightened stress level, the body experiences an increase in sympathetic tone, creating a positive chronotropic and elevated blood pressure response seen in both resting and in exercise vitals.
RER, heart rate, and RPE remain successful criteria for determining maximal exertion. Other research aligns with our findings. Greater than 85% age estimated heart rate max is shown to be a valid VO2 max criterion. Only RER is a more validated VO2 max criterion, and this is supported by a vast amount of research. RPE is also shown to be a valid primary VO2 max criterion, and is correlated with heart rate, RER, and VO2. Some research suggests RPE is not a valid secondary VO2 max criterion, unless the scale is explained via a trained clinician. In our study, RPE was explained effectively and thoroughly by graduate students with clinical experience, which allowed for accuracy. Research suggests that RER may decrease with age despite the participants' perceived exertion. The decrease in RER with an increase in age is caused by a shift from carbohydrate to fat metabolism. Due to this, an RER value of greater than 1.1 best accommodates all age groups, which is demonstrated by our research. In conclusion, RF may vary based on cancer-related toxicities, specifically pulmonary, cardiovascular, and liver toxicities that may alter how the respiratory system functions. Overall, our data does not support an RF value of greater than 40 breaths per minute as a valid secondary VO2 max termination criterion for cancer survivors.